Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. The MJA acknowledges the traditional owners and custodians of the land on which we live and work across Australia. This podcast was recorded on the lands of the Wangal people. I pay my respects to their elders past and present. The lung cancer screening program was introduced last year, designed to help with early intervention for Australia's deadliest cancer. So how is it faring? To discuss this, our special guest today is Professor Fraser Brims, who is a consultant respiratory physician at St Charles Gairdener Hospital and Curtin University in Perth. He has written the perspective for the MJA on the program, calling for more investment so it can reach its full potential. He joins me now. Can you provide us with a recap of the National Lung Cancer Screening Program that was implemented last year?
Yes. So 1st of July, the National Lung Cancer Screening Program was rolled out. And this is an amazing collaboration between Cancer Australia, many consumer and advocacy bodies such as Lung Foundation Australia, and the NACHO groups as well. So this really is the first new screening program for cancer in Australia in nearly 20 years, and it's using low-dose CT scans to identify high-risk individuals who have risk factors for lung cancer. And we know that if we're able to target a high-risk population, then you can find cancers or lung cancers at an early stage, and at which point they can be curative treatment. And that's off the back of a couple of very large international studies that have really changed practice around the world in recent times. The criteria, the eligibility in Australia is age 50 to 70 to have no symptoms that could be consistent with lung cancer, to either be current smokers or less than 10 years since quitting, and have more than 30 pack years of tobacco exposure.
Okay, so can you tell us what was concerning about the 2023 Australia and New Zealand lung cancer landscape survey?
Sure. So the landscape surveys have been a biannual event, and we've actually have completed the 2025 survey, and it shows kind of similar things actually to what's already out and been published in the 23 survey, which was that there are core recommended staffing numbers and multidisciplinary members for multidisciplinary teams for lung cancer, that the majority of Australian institutions do not have those core members. And also, perhaps more disturbingly, is that many of these institutions, or less than the three quarters, are actually routinely discussing every lung cancer patient, or even most lung cancer patients that come through their institution. And we know for many years now that the impact of multidisciplinary team meetings is very powerful, and so much so it actually produces a survival benefit. And this is off the back of international data again, but also from the Victorian Lung Cancer Registry has shown there's a clear benefit at 1 year if your patient is discussed in an MDT meeting. And yet in Australia, we have patchy membership and inadequate membership. Many MDT teams are not discussing all their potential patients with lung cancer coming through. So for me, that's a big red flag about our infrastructure and to manage lung cancer across the public and the private system as well.
Why do you think that's happening?
Look, I think honestly, it's historical. It's a little bit cultural, and I think it's kind of just been allowed to develop without perhaps the clear and defining leadership from government as to what needs to be done. The optimal care pathways for people with lung cancer, first published in 2014, were very clear that the patient should be seen in an MDT. They were updated in 2021, and yet adherence to these pathways in many different ways, not just the MDT, is very patchy in places, and even knowledge of them in places is quite patchy as well. So I think, and I guess the core of the perspectives paper in the Medical Journal of Australia was really saying that I think we're allowing the constraints of our healthcare system to dictate the standards of our care. And actually, it needs to be the other way around. We need to say, no, these are the standards our patients require, and actually make the health service more accountable for providing the internationally acknowledged standards.
So how important is that MDT, as well as the nurses you mentioned in the nursing in your paper?
Look, it's extremely important. It's a core part of how we should be managing all types of cancer, not just lung cancer. You mentioned specialist nurses, and again, there is a significant literature now demonstrating that the presence of a specialist lung cancer nurse throughout the diagnosis time, the workup to during the diagnosis and indeed afterwards, it can reduce the risk of early death, unnecessary hospital admissions. It increases the uptake of systemic therapy, such as chemotherapy, but also even things like surgery, and improves coordinated care. So an incredibly valuable resource. We're entering an era now, quite rightly, of very person-centered medicine. And the voice of the lung cancer community is very clear, as they are desperate for more nurses. And across all of Australia, we have less than 50 lung cancer specialist nurses for what is the lung cancer is the leading cause of cancer death and the highest burden of disease in Australia. And if you compare that to some of the other common cancers, there's a profound imbalance in that nursing support.
Why do you think that's the case? Why is there such a small handful of nurses for lung cancer?
Look, I think there's a lot of different reasons. Again, it's just history. It's just been allowed to develop that way. Honestly, there is clearly stigma and bias against lung cancer, be it conscious or unconscious. We know that even funding for lung cancer research is actually inversely proportional compared to the burden of disease. And it's really hard to get significant funding for lung cancer across the line. And even if you're literally in the street shaking a tin trying to get people to throw a few gold coins in, lung cancer does worse off than other cancers. I think there are pretty many reasons for that, and I'm not an expert in that area, but perversely, it is as a result of the very successful tobacco control measures in Australia. People are really aware that smoking causes lung disease, as it does many other cancers, as it does cardiovascular disease and otherwise. And yet we know that individuals with lung cancer are stigmatized, and there's an assumption that people have smoked just because they've got lung cancer, which we know is wrong. We know 1 in 5 lung cancers now in Australia are in never smokers. So there is a bias against lung cancer, and even heartbreakingly to the point that some patients themselves say, well, I guess I deserved it. I brought this upon ourselves. And that, as a clinician, when you're breaking bad news or talking about care for people with lung cancer, is just heartbreaking to hear. Nobody deserves cancer, no matter what's happened in their past ever. So it's a very vexing topic, and something that I think needs a lot more discussion and open discussion, trying to break down some of those barriers and misperceptions.
Yeah, because there's not that same judgment towards alcohol and how many cancers that it contributes to.
Indeed. Or even, someone with, let's say, colon cancer. You don't say, gosh, you must have eaten a lot of red meat in the past. Or melanoma, gosh, you must have been out in the sun too much. It's no other cancer are you judged by a risk factor. And as we found with, and it's only approximately 1 in 5 individuals with lung cancer now are current tobacco users. Either the rest have never smoked or they're actually managed to give up their addiction. So again, people have done the right thing, and it's the legacy, unfortunately, of tobacco exposure that raises that risk for lung cancer in the background. And there are many other risk factors for lung cancer, many of which are beyond individuals' control as well, particularly family history, as well as sort of air pollution and air quality, occupational exposures, and otherwise as well.
Do you think that stigma around smoking, whether it's now or the past, puts people off putting their hand up to have a lung cancer screening?
Yeah, look, that's a real concern. And I think the perception also, both in the community, but also to a certain extent amongst medical professionals, has been a lot of nihilism about lung cancer. Oh, well, it's too late. I won't survive anyway. And so the National Lung Cancer Screening Programme has been designed primarily to try and reach the priority populations, and very much with issues like that in mind is that how can the media and the communications go out in such a way, not to sugarcoat something, but to be positive and say, actually, this is a really exciting, good step forward, and to try and break down those kind of historical views. And it is a brilliant step forward. There's no two ways about it. This is going to be transformational for lung cancer in Australia.
You mentioned also that it's a good opportunity when people come forward for the screening program that clinicians can talk about smoking cessation, and as well as that it's not too late if you stop smoking to make a difference. You mentioned that.
Hugely important, and really, if you look at all the sort of algorithms for clinicians having a patient-centered discussion around screening, all of the little arrows all point to smoking cessation in there as well. So it has to be integrated. It is, I hope in the future, the program will more formally integrate the requirement for smoking cessation, even perhaps incentivize with MBS item numbers, that kind of thing. But we know that if you integrate smoking cessation into a lung cancer screening program, then the effect on all-cause mortality is well beyond what screening can manage alone. Because, of course, there's 16 other cancers that smoking causes, and there's cardiovascular disease and many other aspects as well other lung disease, emphysema and bronchitis and so on. So the impact is huge. And generally speaking, if you have an individual who's considering lung cancer screening, then they are hopefully in a space where they're wanting to improve their health or have concern around their health, and generally people are quite receptive at that point for smoking cessation support. So it's massively important.
Does that cessation include vaping? Because obviously you're at the pointy end of being a smoker when you come for a screening test.
Yes. So I guess it's important to say that currently the screening program, e-cigarette use for vaping is not part of the criteria, but there's a huge concern at the moment around the vaping and e-cigarettes. There is emerging data, certainly of an association of e-cigarette use and lung cancer. There's data demonstrating that individuals who use e-cigarettes to help with them quitting their tobacco use actually possibly even have a raised risk for lung cancer in the following 5 years. That's data from, I think it was Korea. So vapes, I think, should be regarded as equals to cigarettes in terms of risk and how they're not a sort of a softer alternative. And really we need to, as a community, but actually as a country in terms of our sort of laws and practices, really try and minimise the availability of e-cigarette use. And of course, at the other end of the scale, for teenagers, they are a gateway towards tobacco use. And that's a huge concern as well. We know if young teenagers vape, then they're at least twice as likely to start tobacco use later in their teens.
Right. So what is the importance of access to personalised medicine investigation?
Sure. So in the last 10 years or so, there's been some wonderful, amazing advancements in the understanding of genetics of lung cancer. And we're at a point now where we know of more mutations within lung cancer tumours than there are therapies for them. And this is why there's been really an unprecedented investment of time and money from pharma companies to try and help target these mutations. And we know for the medicines that are out there already that there can be some really dramatic changes for individuals that do have these mutations. In Australia, the molecular testing is called next generation sequencing, or NGS, which is quite widely available. But again, our most recent landscape survey has demonstrated that it's a little patchy in places, and there's frustrations around the timelines to get those answers back to start treatment in a timely manner. So those are so-called targeted therapies. And then I think everyone's probably heard on the lines of immunotherapy as well. And again, so lung cancer is in some cases very susceptible to immunotherapy. And so there's been a great deal of advancement in those combinations of treatments and timings of treatments and otherwise for that more personalised care. And all this, again, the complexity of managing or even planning to treat lung cancer has really gone up hugely in the last 10 to 15 years. And again, this underlines the importance of that multidisciplinary team, because it's not straightforward now. I think it was a relatively straightforward process 10 to 15 years ago, and it's really not now in terms of how we manage and treat with systemic therapy, at least, with lung cancer.
So what about the importance of clinical quality registries and data platforms?
Thank you. Yeah. So we know from experience in Australia, but also around the world, that clinical quality registries have the potential to significantly recognise and improve unwarranted variations in care. And we know in Australia there is without doubt a widespread unwarranted variation. And I guess the what's an unwarranted variation? It's where that you can't explain it by access to treatments or patient differences. So it's something to do with the infrastructure or the provision of diagnostics or treatments or otherwise along the line. And there's been many studies over the last, decade, at least 15 years or so from Australia, all demonstrating different variations in care. And it's really almost a repeated picture. So we know that Aboriginal and Torres Strait Islanders have at least twice the incidence of lung cancer, but they are twice as likely to die from that lung cancer as well. Immigrant populations, culturally and linguistically diverse populations have worse outcomes. If you're older, you have worse outcomes. Private versus public have different outcomes, different or lower socioeconomic status, and even rural and regional patients have different outcomes, different access to care. And this was, in some ways, part of the reasons to the landscape surveys, was to try and understand where care is provided. A clinical quality registry has the potential to collect routine, clinically available data around the time of diagnosis, to benchmark those data against nationally agreed quality indicators, and importantly, to compare those data against peer hospitals, a bit like the Health Roundtable can do, but also against where the national targets are as well. And probably the exemplar of this in lung cancer is through the National Lung Cancer Audit, which is in the UK for mostly England and Wales data. That's been running for 20 years, and there's no doubt whatsoever that has utterly transformed the quality of lung cancer care in the UK. And so I'm part of a collaboration trying to get something very similar established across Australia as well, which is, so that there's a need for a sort of a collaborative lung cancer clinical quality data platform, which will allow centres to collect their data, to submit it. It gets benchmarked, fed back in a very timely fashion. So we have a process where people can see literally last month's worth of data. And this important also then links into the National Cancer Screening Register as well, because there's a real importance to get timely data around staging. And are we, as increasing numbers of people get screened, and we're seeing by the time this goes to air, probably more than 70,000 people will have had a CT scan through the National Lung Cancer Screening Programme. We need to know those individuals are getting timely care. We need to know the stage. We need to know if they're getting surgery. And otherwise, our cancer registries across the jurisdictions will not collect all of those data. And if they are collecting that data, it can sometimes take a year or even 2 years to make it back to the the Australian Institute for Health and Welfare. So there's a real need for contemporary data, which will look at guideline concordant care and feed it back to hospitals. And our pilot data, which we've been running in Western Australia, has been incredibly illuminating. Everyone is working very hard, and there's no question around individual hospitals, and what it's demonstrated is really a system-wide weakness in the infrastructure for managing patients with suspected lung cancer.
So what trends are you seeing, can you say, in the data that you've been collecting in WA?
So I guess we're seeing, one of the first principles we did is look at what are the clinical quality indicators around in Australia, and also to look at aligning those with the Cancer Australia Optimal Care Pathway guidelines. And one of the things we found is there are a number of other registries and other groups collecting routine lung cancer data. And to this point, no one is collecting the data required to measure the Optimal Care Pathway guidelines. So we're 12 years on from when they were first published. And importantly, a very patient-centred, very important measure is time from when your GP or primary care provider refers somebody in to when they get seen in the hospital. And that should be less than 14 days. And until we started this process, no one's collecting the data at all. So, and to collect all of the various groups' proposed clinical quality indicators, there were 69 different indicators across Australia, and none of them were comparable against each other. So we've got different jurisdictions, different collections of hospitals collecting data, and we can't compare across the nation. So there's a clear need for nationally agreed quality indicators. And so as part of a PhD, one of my colleagues has been going through that process, and then we've applied that, as I say, as a pilot within Western Australia. And what it showed, I guess, to just be very frank, is a system-wide failure to be able to see patients in a timely fashion. What's very clear is once individuals are into the hospital system, the public hospital system in particular, the quality of care is actually pretty good. There's a lot of indicators being met and being met well, and there's no question of that. But there is a squeeze right at the start to get patients in. It's led to some direct investment from WA Health, which has been very refreshing. But I think it's also led to an interesting conversations around, does every single patient need to be seen within 14 days? If you ask patients, 100%, yes, they should. I think it's very difficult to have this discussion, but there are nuances around different lesions in the lung which may be suspected lung cancer, because something that is say an 8 millimeter, quite faint shadowing on the lung, so I've got a non-solid nodule, has a very different risk profile to something that's a 5 centimeter big solid lump. And one of them definitely needs to be seen very quickly. The other one, the non-solid nodule, that might be a lung cancer, but actually time is on our side. So that there are complexities around this, and perhaps one side doesn't fit all. But mentioning again, we're in a person-centered era now for healthcare, and this is a very important that initial contact with the hospital or healthcare providers for patients is extremely important, and I agree with that completely. So there are challenges, as I said, and going back to what we said before, is currently the healthcare system is not able to be responsive to the needs of our patients at the moment, and that I think is a bigger, opens up a sort of a bigger discussion around person-centered care in this century and indeed in this decade.
So why it brings up the question that if you're going to roll out this program nationwide, the first ever for lung cancer screening, wasn't the next steps taken care of in their forecasting?
Look, I think everything's moving very quickly with lung cancer, and a lot of these processes are almost moving in tandem. I think once we got momentum with the possibility of getting lung cancer screening, and the ministers for health were supportive and have been very supportive across successive governments, there's no way we were going to try and put the brakes on it and say, oh no, hold on, maybe we need to look at something else. This is groundbreaking and probably the most important thing to happen for lung cancer in decades. So again, to the point of the Perspectives article, is the rest of the system now needs to catch up, and we need to really achieve the full potential of screening, with all the awareness it creates and the hopefully breaking down stigma and nihilism and all those things. Really now's the time to focus on the bigger picture of managing patients in a contemporary way, which is complex and has different demands than how it did, say, 20 years ago.
One of the things you mentioned in your perspective is biobanks. What can they do for lung cancer?
Look, they again. So I've mentioned things are changing really fast. One of what I guess is worth saying, Australia has some really world-class facilities and researchers in this area. The potential is, if we're clever about investing in a national model, a framework, then if we can sequentially capture perhaps certainly the screen detected cancers, but others, then we can really understand why some patients respond to some treatments and some don't. Go back a step, why are some never smokers? Do they have different genetics or different changes within their tumours? Sometimes we know immunotherapy for many is great. For some, on the face of it, with our current knowledge, it should work for some patients who have high programmed cell death ligands, but they don't respond. So there's still other aspects to the stories. And I think sequentially collecting biological samples, tumours, lymph node biopsies, this sort of things will allow this explosion in so-called now multi-omics analysis to really try and pick up why some patients respond and some don't to different therapies, and to really drive that really strong foundation that Australia has about translational research as well. So I think there's the need to, I guess, as a community, be a little bit, in my opinion, be a little bit more joined up in how we approach this. And again, rather having 3 or 4 strong institutions doing similar work, maybe it's overlapping, maybe it's not. It's just to agree, a body of a program of work, if you like, between all these strong institutions, hopefully with, funding, tier 1 funding from NHMRC, MRFF and others, and then we can be very impactful, very deliberate in how we deliver some of the advances that are needed.
When you talked about the different groups that were missing out on proper care, or they had worse outcomes earlier, it's obviously they're getting access to the screening program and the public health system. Where is the system failing these people?
Gosh, that's not an easy one to answer. So I guess to link in something in particular, so one of the unique aspects of the National Lung Cancer Screening Program is there's provision of mobile CT scanners to get out into traditionally the hard to reach areas. So right now, the northern part of WA, so the Kimberley and Pilbara region, has a bus called Heart of Australia 7, because it's the 7th one, touring around and recruiting individuals from these remote communities. And many hundreds of people have been scanned, and I can't say the precise numbers, but several lung cancers have been identified at an early stage. So again, that's, I guess, an example of how the program's been designed to try and support these hard to reach people. Otherwise, the gaps are just going to get worse if we were to only ever have something that sits within the metro region. As for how, I guess, provisions of care and otherwise, there needs to be quite targeted work on particularly trying to understand access to care. What can be done to improve access? Is it kind of coordinators? Is it just, I guess it's going to be many different things, but again, is it the nihilism? Is it just, there's just no point, I don't want to travel? Can we improve the understanding, break down some of the perceived barriers? Can we, in places, provide care more locally? Now, some of that, for some of the complexity in these days of managing lung cancer, then honestly, no, we can't. But I think for some of the treatments, like say radiation treatments and systemic anti-cancer therapy, then perhaps we could improve regional support. But I think there does need to be a big body of work on supporting rural remote in particular, to understand those barriers, real or perceived, as to what makes accessing care difficult, what are the delays. And that's across the board, that's primary care, Aboriginal medical services and so on, as to how we can improve that pathway.
What needs to be done for the full impact of the screening program to be realised?
So I think it's really a holistic approach across the whole foundation of lung cancer care. So I think there needs to be wider, and I'll go as far as saying universal access to multidisciplinary teams, discussions. If someone has potential lung cancer, they deserve to have their case discussed in a properly staffed multidisciplinary team discussion. And we know there is a survival benefit if that's the case. So it's hard to argue against that. I think we need timely access to personalised medicine, such as that next generation sequencing, genetic testing I was sort of talking about as well. I think there's no doubt the perception amongst the community is that a lung cancer clinical quality platform it has the great potential to significantly, really shine a light on areas of care that need to be improved, or care provision that needs to be improved, and indeed actually celebrate areas that are good already and learn from them. Smoking cessation, hugely important, and I think access to MBS item numbers, and the bigger picture we haven't spoken about is this concept of a tobacco-free generation, which is being mooted. Actually, we can change the law to sequentially each and every year increase the legal age of being able to buy tobacco. So essentially over time, you actually make tobacco never available to an entire generation. That's something that New Zealand have very nearly got across the line. It's something in the UK at the moment. The House of Lords have just added to a bill about tobacco control in the UK. So it's getting there, and I think Australia needs to look very, very hard at that. We mentioned about the research platforms and just linking, and perhaps I think perhaps more joined up collaborative approach for that, to really utilise the benefit of the great research and translational work we have in Australia. And of course, perhaps most importantly, is more determined, sustained efforts to support Aboriginal and Torres Strait Islander peoples, and that's got to be led principally from the various bodies and NACCHO and otherwise that look after these processes, and of course with whatever support that the rest of the cancer community can provide in there.
You're so focused on this particular research. What motivated you to get in this in the first place?
I've often asked myself that question. I guess I've spent 25 years looking after patients with lung cancer, and I think honestly one of the things that hits me hardest is when patients say, "Gosh, I guess I deserve this, doc." It's just heartbreaking to hear that. I guess on a personal level, I kind of always support the underdog, and lung cancer is no doubt the underdog in the bigger picture of cancer control and cancer outcomes in Australia, but actually, frankly, across the world. It's the leading cause of cancer death in the world, and that's not going to change in the near future. Projected rates, even in Australia, are due to carry on rising for the next 15, 20 years. So the problem is not going away, and unless we invest in this and have a national conversation about where we're up to with this, then it's these variations in care and importantly these priority groups are not going to be well served.
Thank you to our special guest, Professor Fraser Brims. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thank you so much for listening.